E.G. is a 16-year-old Hispanic male who presented to the clinic with lower back pain. Patient had lower back pain for one day. He reported running into someone while rebounding during a game of basketball. He rated his pain at a 9 out of 10. Reports pain is sore and achy type, located primarily on the right lower back. He reports pain becomes sharp and worse when sitting, bending, or twisting. Denies radiation of pain. Lying flat on his back and using ice makes the pain better. Denies use of any over-the-counter pain or anti-inflammatory medications. Denies pain with breathing, BMs, or urination. Past medical history. Denies current or previous health problems, illnesses, or injuries other than his current complaint. Denies surgeries, procedures, or hospitalizations. Past social history. Patient is currently in the 11th grade at Sheridan High School. He plays on the school's varsity basketball team, denies use of marijuana, drugs, or alcohol, lives with mom, dad, and older brother in a single-family house. Denies current use of medications, vitamins, or herbs. No known drug, food, or seasonal allergies. Denies any significant family medical history. Upon review of systems, starting with musculoskeletal, other than his new lower back pain, he denies any other tenderness, swelling, muscle cramps, joint stiffness, neck or shoulder pain, or range of motion limitations at this time. Respiratory, denies shortness of breath, cough, dyspnea, wheezing, and hemoptysis. Cardiovascular-wise, denies chest pain, dizziness, lightheadedness, orthopnea, or palpitations. GI, denies nausea, vomiting, diarrhea, constipation, or dark, bloody stools. GU, denies changes with urination, denies dysuria or hematuria. And neuro, denies change in sensation, numbness, or tingling in all of his extremities. So based on his review of systems, for his differential diagnoses, I went ahead and decided upon lumbar strain, herniated disc, and lumbar compression fracture, and then moved on to the physical exam. So upon physical examination, starting with musculoskeletal, he had normal stability and gait, slight redness and warmth on the right lower back, lumbar spine symmetrical, forward flexion was limited to about 70 degrees before reporting pain, right lower back is tender to palpation, 5 out of 5 strength and full range of motion in neck, shoulders, arms, legs, and feet. Respiratory-wise, no thoracic asymmetry was noted, respiratory excursion was normal and symmetric, lungs were cleared, auscultation bilaterally, and no adventitious breath sounds were heard. Cardiac, S1, S2 were regular in rate and rhythm, no S3, S4 murmurs were heard, normal cap refill time, and 3+ radial and dorsalis pedis pulses. Neuro, he was alert and oriented ×4, sensation was equal bilaterally in upper and lower extremities. And GI, soft, non-tender, abdomen, bowel sounds were present in all 4 quadrants. At this time, no diagnostic labs or imaging were needed. Based on his physical findings, I would diagnose him with a lumbar strain. So for management plan, I instructed him to continue with application of ice pack to lower back for relief of pain as needed, to take ibuprofen 400 milligrams orally every 4 to 6 hours as needed for pain, not to exceed more than 3,200 milligrams per day divided into 3 or 4 equal doses. I also told him to take it with food or drink to reduce the chance of upset stomach. I also instructed him to avoid lifting more than 20 pounds and any activities where bending, twisting, or potential physical contact occurs for the next 2 to 3 weeks. Lower back muscle strains typically heal within 3 to 4 weeks. So if lower back pain still hurts after 3 to 4 weeks, I want him to return to the clinic. I also instructed him to return to the clinic sooner if pain worsens or radiates to another body part or decreased sensation, numbness, tingling in legs, shortness of breath, or pain with BMs or urination occurs. Moving on to special sections. Section C, thoroughly describe the setting the patient encounter occurred in. My patient was seen in the Sheridan Youth Health Clinic, which is a school-based primary care clinic. It is staffed by providers from the University of Colorado College of Nursing. It also provides behavioral health, dental care, and pharmacy services. Number 2, describe the typical patient population served in the setting. The typical patient population consists of children from birth to 18 years old, and they generally come from a household of lower socioeconomic status. Number 3, thoroughly describe the health disparities faced by the population served in this setting. Let's see, what impact have these health disparities had on the pediatric patient's growth, development, and social functions? So families of low socioeconomic status face many health disparities, one being poor health outcomes due to a lack of resources, low health literacy, and healthcare costs. These disparities may result in a delay in the pediatric patient obtaining healthcare due to financial issues, lack of accessibility, or support from their caregivers. The lack of healthcare with this population can result in the development of chronic illnesses due to not receiving preventative care, chance of contracting disease due to a lack of immunizations, and a lack of screening for abuse and behavioral health issues. And number 4 from section C, describe how the agency you worked with has impacted the patient's health status. The goal of Sheridan Youth Health Clinic is to make healthcare and medical resources more accessible to children who might otherwise have barriers seeking medical attention. By having the clinic in a school, it makes receiving medical care more convenient and increases the likelihood that children will seek medical attention. As a result of this clinic being easily accessible, my patient was able to have his healthcare needs addressed within 24 hours of his back injury by coming in during a break between his classes. This should result in a quicker healing process due to recommendations provided to him and less likely to have complications. And that's it.